Yes, so good evening, everyone. A very warm welcome to all of you who have logged in for the second parallel session for the second day of the three-day international web conference organized by the Naga Scholars Association on the theme of living in the present, Nagas in the 21st century. It is a delight for me to be a part of this session on health and society, which is a very current and a relevant topic. When we mention health and society together many a time, we feel as if we're talking about two different things. And in a sense, that is true. But beyond that dissimilarity, there is an entire world of symbiosis whereby the state of one affects the state of the other. Both health and society are interrelational, and the well being of one builds the other, or vice versa. Of course, when we say health, we're also looking at health in an integrated way that encompasses all kinds of well being: emotional, mental, psychological, physical, and spiritual, even. Health and society as a field may not be as much researched to a Naga society as compared to many other fields, but it is in no way a new field. There are numerous researchers being carried out in this area by our Naga scholars, as this field of research is interdisciplinary, involving knowledge, methods, and researchers from different disciplines, but more importantly, as it is a very pertinent issue in every society, as with a Naga society. We all know that the 21st century and its boom has brought along a huge shift in food, lifestyle, culture, an entire avalanche of change. And so, talking about health and society and its implication towards each other has become even more important. If the social and the environment changes health, then health or health condition in turn can also change society. Look at the current situation we are in because of the pandemic of COVID-19. It has affected our health definitely and destabilized the functioning of a society in many ways. And this emergent crisis across the globe has brought us to realize that it is high time for us to understand health from a holistic point of view and to see the concept of health beyond the perspective of the sociology of sickness and illness and to consider it to the wellness of society. Today's session on health and society will be addressing a lot of these concerns and more, and I am honored to inform you all that we have an array of distinguished speakers and paper presenters in this segment. I will first start with the introduction of the speakers because I'm not very sure if the chair is here as yet. So let me take this time to introduce the speakers. The first speaker for today's session is Dr. Sedevi Angami. Dr. Angami is a gastroenterologist and the director of the Christian Institute of Health Sciences and Research, Dimapur, Nagaland. Dr. Sedevi Angami is also formerly a lecturer and a senior registrar of the CMC Vellore. And prior to joining CIHSR, he was a consultant at Bethel Medical Center, Kohima. He has recently been appointed as a member of the newly created National Medical Commission, Ministry of Health and Family Welfare, Government of India. Dr. Sedevi's interests are developing people, mentoring and coaching, networking resources and people. And the topic that he will be speaking on today is towards a healthy society in Nagaland. Thank you so much, Dr. Sedevi, for agreeing to be a part of our session on health and society today. Let me move on to the second speaker for today. The second speaker is Reverend Dr. Ellen K Jamir. Dr. Jamir is an associate professor of pastoral counseling and psychotherapy at the Oriental Theological Seminary, Dimapur, Nagaland. She will be speaking on the topic of mental illness, the invisible misery. The third speaker session will be M. Kyothunglo Humtsoi. Ms. Humtsoi is an assistant professor and a clinical psychologist at the Cluster Innovation Center, University of Delhi. Besides a teaching career of more than 10 years in the University of Delhi, Ms. Himjoy provides consultative services to students of University of Delhi. She was formerly at Jawaharlal Nehru University and Apollo Hospital, Noida as a clinical psychologist. She will be speaking on the topic maneuvering identity, morality, and mental health. Thank you, Ms. Himjoy, for being a part of this session. The fourth speaker for this session will be Dr. Kyobini Morji. Dr. Kyobini Morji is an assistant professor in the University of Tennessee Health Science Center. She will be speaking on the topic of indigenous genomes in the era of precision medicine and big data. Thank you, Ms. Morji, for being a part of the session. The fifth speaker then for the day would be Ms. Pansi A. Jami and Ms. Chimtanglo Yanthan. They are both research scholars in Jawaharlal Nehru University, and the topic of their paper is Role of Women in Situating Indigenous Food Knowledge of the Lotha Nagas. Then the sixth speaker of the day is Ms. Guang Dekluanlu Riamai. I'm sorry if I'm not pronouncing it right. Her paper is titled Nutritional Status in Relation with the Place of Residence Among the Rongmai Naga of Manipur. Ms. Ramai is a research scholar in the Department of Anthropology, Northeast Hill University, Shillong. Before we move on, I'd just like to, check if the chair is here. Dr. Sushmita Das Gupta, are you here? Okay, since I don't see her as yet, since it's already, much into the session, 14 minutes into the session allotted for us, I think we should start ahead with the first topic of the day. I'd just like to remind all the speakers that since we are working within a time foundation, you're all requested to please conclude your paper within 15 minutes, your paper or your talk within 15 minutes. And yes, so without further ado, then Dr. Sedevi, I hand over the time to you.
Good evening, and thanks for inviting me to this meeting. I'll just start sharing my screen. I've been asked to talk about health, and so I was thinking about the current status of health in Nagaland and where we are heading towards, whether we are actually a healthy society and some of the things which we could work towards. So in 1978, there was a big gathering in Alma-Ata, and they had this declaration called the Alma-Ata Declaration, which became very famous, and they talked about health as being a state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. And they, I guess, were not very religious, so they didn't add spiritual well-being. But for several of us, we know that the spiritual well-being is as important as all the others. They declared that health is a fundamental human right, and that by the year 2000 AD, everybody in the world should be able to reach a level of health that would permit to lead a socially and economically productive life. We never reached there. And when you look at health, people, when they look at the health status in a region, normally the first things that they're going to come up with is the indices: infant mortality rate, maternal mortality rate, immunization rate, how many hospitals you have, or the doctor-patient ratio, or the nurse-patient ratio. And they think these are very important. And if they see that these ratios are getting better, then they say, yeah, you're doing well, your health is not bad. And therefore, the entire health policies of the country are also directed towards addressing these indices. And definitely these indices are important, but it's not everything. It's just not control of diseases, whether it's communicable or non-communicable, is not it. We know that there are several medical colleges in the country. There are about a little over 500 medical colleges, and they think that if you can double the number of medical colleges, double the number of doctors, improve the ratio of doctor-patient from 1:1,600 to 1:1,000, then things will get better. But that is not really the case. Now we've moved from health for all to the sustainable development goals. We had the Millennium Development Goals and now Sustainable Development Goals, out of the 17, the third goal is really related to good health and well-being. But actually speaking, almost all the 17 others are related to health in some way or the other. And health, like our chairperson said, cannot be treated in isolation. There are several variables which relate to health. And these are called the social determinants of health. Now, if you look at the social determinants of health, what are its contributing variables? It's related to economic stability, healthy physical environment, education, adequate food, and a healthy community, and also effective healthcare system. There are several others, but these would be the predominant ones.
Excuse me, Dr. Sadevi, can I interrupt for a second?
Yes.
The screen that you're sharing, for some reason, it's not seen. I mean, like part of it is not seen. We can just see a quarter of the screen.
Okay, then I'm not sure what I can do about it because it's always worked.
We can still see only quarter of the screen.
It's visible at my end, Jasmine.
It is?
Yes, it is.
Oh, then it must be
Probably
worse.
then it's just here. All right, all right.
Okay,
Yeah, please
okay.
carry on. Yeah.
Okay, yeah. Yeah, my apologies to your computer. Okay.
Sorry.
Okay. Yeah. So now, if you're looking at these factors or variables, and we apply it to Nagaland, economic stability. Various factors about this about employment. Now, COVID has brought a lot of unemployment. Government was trying to generate employment, sending all the Nagas outside. They've all returned back. Decades of work has been undone, and now they all come back. And employment is very important because apart from just generating income, a decent income, it also preserves the dignity and well-being of a person. When you're working, you feel a sense of well-being. In Nagaland, our people don't really know how to save. They're predominantly a spending community. And, even in our own hospital, we keep telling people how to invest, how to save. And whenever I ask, a crowd of like 20 people, how are you saving? Very few people actually save. And so they all, they need extra money, they have to take loans. And the loans in Nagaland are, at very severe interest, like 10 to 15% interest. And so economic stability is also keeping people from falling into debt, and affordable healthcare expenses and support for medical bills. Hospitals are very, very dangerous places to go to. I run a hospital, and we know that things can be very expensive. The World Bank has done a study which says hospitalization is the single most important reason why people go under the poverty line. So although I need patients to come into our hospital to keep it running, but if we could prevent people from being hospitalized, it would be really good, so it would prevent them from falling under the poverty line. The second is a healthy physical environment, another variable related to health. So we need recreation avenues. And in Nagaland, we need to look and say, how many more can we create? The churches might need to look at this and say, can we create more recreation avenues? Government has to work at it. The social organizations will need to look at it. Because if you don't, then you get into alcohol. Decent housing and sanitation, freedom from violence. During this COVID crisis, there have been lots of reports that domestic violence, sexual violence at homes have actually increased. Sport and art, safety and freedom from conflict. You just need to look at the Rohingya crisis or the Syrian refugees, or now in Ethiopia going on to Tigray. The refugees, when they go, they just lose everything related to health in relationship to everything but a large amount to health. And so conflict can destroy in a minute what took us years to build. Good roads are necessary for health because you can develop all your institutions. Recently, I was listening to a person from Delhi, from the central government, talking and saying that, or UNICEF, he was saying, we just look at the demand and supply. In Nagaland, you don't have very good health centers. You build the infrastructure, give them equipment, etc. Now you have the supply, you just now need to create a demand. But you can't reach, if you can't reach the hospital or the health center, then that demand and supply doesn't work. So we need good roads without which, and therefore I believe churches should get into making roads, safe water, and we have a lot of cable water in Nagaland, in Kohima, even after 60 years of independence. We still don't have it. So thirdly, one of the major determinant of health, and that's why we are getting a lot into this, into school health education, is education really changes health. Some of the basics are, of course, acceptable literacy. Higher education in Nagaland is, of course, almost non-existent. Modular education is one area where we need to look at very carefully, because changing an entire college or school may not work out, but very good modules which you can put in small portions can make some changes. And vocational skills and training. One thing which I have realized after trying to run an institution for 13 years is our people lack a lot of analytical and critical thinking skills, problem solving skills, and they don't have reflective learning. So we need to really put all these into our education. If you're not doing that, then it's just rote learning. And the National Health Education Policy is trying to address this, but it's not too easy because you have generations of teachers who never had this. Now you're going to tell them to teach students, and they themselves are not skilled in this. So health should be part of the curriculum. Then food. We need adequate, wholesome food. The public distribution in Nagaland is almost non-existent. And therefore, as long as you try to have the PDS being distributed by the government or the village councils, is not going to work. The village councils are extremely corrupt. Government, there's not much hope. And therefore, I think if you can get churches to get involved in this, because people who work the same people in the church and the village council behave very differently. Reliable NGOs like ECS, in Twinsam, they're doing a fantastic job. And then adequate nutrition or sustainable agriculture. With COVID, we realized we need to get back into agriculture. And Nagaland's got such great land. If we can only use our land, well, the population is so small compared to our land. Even though it's a small state, we can really generate a much better support for health. And then effective healthcare systems. We talk about adequate health coverage for all, and medical care accessibility and affordability, and quality of care. Quality is not something which people think about much. Essential drugs availability and preventing diseases. In Nagaland, we have a community which is quite cohesive, and therefore we do have social support systems, but we need to optimize this community potential. When a person has a stroke, he normally has initial 1 or 2 weeks of very good support, but then after some time it just peters off, and then for 6 months there's very little support for people. The community integration and proactive engagement in health. The community has to start saying health is our responsibility, not the government's responsibility, not somebody else's. They need to say we are going to develop a health committee, and we are going to take things very seriously. They must be very proactive. Nobody can help you. The community itself has to say we will take responsibility. Freedom from discrimination is very important. We don't have this caste system and things like that, too bad, but we do have tribalism, and also we do discriminate quite a lot in other areas, so caring for vulnerable and marginalized people, like the elderly, people who are disabled, people with mental illness, migrants and destitutes, especially migrants. I feel very angry when I see migrants being treated badly. The Muslims and the Bangladeshis and all being treated badly reflects very badly on our society. It means we are not a healthy society. So what are the strategies for health? A few days back, one person called me up from Imphal and said, can you help us? And I said, in health. So I said, it depends on what you're looking at. Are you looking at tertiary care, secondary, or primary care? If it's tertiary care, it's very money intensive, manpower intensive. Secondary care is something which is a little more doable, but primary care is something which we can all do. And especially if it's community-oriented primary care, it's very low cost, It is doable and everybody can do it. So we need to really work on primary care. All the three are important, but primary care is one area where we really need to look at. We need to really decentralize the health services delivery. Health is in various areas: preventive, promotive health, rehabilitative, palliative health, and curative. Now, out of these, only the curative part is relating to hospitals. All the rest, the prevention, promotion, rehabilitation, palliation, they're all community related. And therefore, the community needs capacity building in these areas. Hospitals are really actually firefighting exercise centers. And you need a multi-sectorial coordination. You will need the health sector, agriculture, animal husbandry, industry, education, public, PWD, communications, all working together. Now there is a lot of this talk about convergence. And when they say convergence, very often it means having a meeting with having all these people come together. But that is not convergence. That is just a meeting. That is not convergence. Convergence is when they really work together, plan together, and that involves much more hard work. You can't generate convergence by being lazy. So the key agencies relating to health, of course, we know the health department is the predominant one, but it cannot take full responsibility, nor can it generate health. So it needs to open up to partnerships and play the role of a facilitator and tell the community and say, you take responsibility, you tell us how you want us to help you, and we are there to help you. That's where it needs to change. Education, in education, we need to have health as an integral part of the curriculum. It doesn't exist now in the whole country. We need to have health as part of the curriculum from class 1 to class 12. And it must be a very dynamic curriculum. We are quite happy in our hospital, we are working towards that. The private sector, this is a much neglected area. The government does most of the activities and they think that they can do it. No, the private sector is the one where you get all the good brains, all the most innovations are there. The not-for-profit organizations need to be brought into the planning group. If you say, we give you these guidelines, you just follow and implement the guidelines, that's not okay. We need the private sector to plan, implement, etc. And then the church, we need to have professional capacity building for the church. If you just say, church, come and help in health, they won't know what to do. So pastors, deacons, church workers need to be built up. You need to have an actual full health curriculum for the churches. The community must be involved, and they must be involved in every aspect of the planning cycle. They must be involved in planning, in strategic planning, and with that, you need to do participatory appraisals. They should be able to be involved in the designing, looking at the big picture, in the implementation. So they will need to have capacity building and monitoring. So they will need to understand the standards. They need to audit, to review and evaluate. So they must understand the outcomes and impact of any program. And they should also be involved in the next phase of planning. And therefore, we need to build relationships with the community to improve health. The reason why we had so much of hysteria and difficulties during this COVID crisis was the community was never involved in health planning. And that must be a very big lesson to us. If you don't want to have another disaster like COVID affecting the community, please start involving them in planning. We need to do a community resource mapping and try to get all the resources of the community, develop health champions amongst them. Avoid overemphasis on hospitals and curative services. Stop short-term medical camps. Medical camps are useless, absolutely useless. Stop medical camps. It doesn't help. And then when you want to implement centrally directed national programs, you always must have it contextualized to the state. Otherwise, it'll be running for 3 years, 5 years, and you'll find that it doesn't work. And stop project mode initiatives. Do it as a long-term project. I'm going to end with this. There's a man called Gary Gunderson who wrote The Leading Causes of Life. Normally, when you look at a health initiative, you first say, what are the leading causes of death? So Gary Gunderson changed it and he said, look at the leading causes of life. If you look at Naga society, you can actually look at the strengths of the society rather than the ills of the society. So look at connection, how we link with each other. We have cohesion, we can make it stronger. Agency, so how can we have a positive choosing towards life despite all the suffering that we've had during the insurgency and things like that. Generativity or multi-generational belonging, how to be accountable for the generations beyond after us, coherence or making sense of the life and purpose and hope, or risky anticipation or optimism for the future. I believe in 10 years' time, if we work out these and we work together and get our act together, Nagaland is a very small state. It is possible to make a much healthier society than what we have right now. We need to integrate the scripture in health. We need to have shalom, or whole person care. People must be able to flourish and not just exist. And they must be able to have healthy choices. So yeah, thank you for the time that you've given to me. I hope I haven't exceeded too much.
Well, actually, you've exceeded the time by 2 minutes, but since you were wrapping up, yeah, I thought, let's at least allow you to get over with that. But it was a very interesting topic. And you have also, in the course of your talk, identified the lacunas in the health services and also identified the fact that the lacunas can be filled up by all of us, stakeholders, individuals, as well as groups in society together, that we need intervention from the government, definitely, but churches, civil society, all of us, we have a responsibility to play, because health, after all, is a collective responsibility. So extremely informative and very engaging it was. Thank you so much, Dr. Sedevi. Now we will be moving on to the second speaker, Reverend Dr. Ellen K Jamir. She would be speaking on the topic of mental illness, the invisible misery. Now, Dr. Ellen, yeah, I give the time to you.
Thank you, Jasmine. Good evening to all. I really want to thank the NSA for having me during this web conference. It's been a gratifying experience to be in the company of great learners, teachers, and professionals. Thank you, Dr. Sedewe, for your comprehensive presentation. And it's always good to work with you, and I really appreciate your work. My presentation will be very brief, and it's based on my clinical experience. Mental health, the invisible misery. I will be sharing a screen, so please hold on. Okay, there it goes. Okay, I want to start with 3 vignettes, and these are cases that I've encountered in the past few years. First of all, I have named this person Mr. Tiaman. He is a 65-year-old man, married for 35 years, and blessed with 3 beautiful adult children. At first glance, Mr. Tiaman seems to have it all in terms of what makes up life. A family, a nice house, cars, and a retired life after many years of service in the government sector. However, therapy sessions with him revealed his deep pain, living with depression and anxiety. Daily life and activities were hard for him. He struggled to get up in the morning, had lost appetite, and sleep was disrupted. He described his loss of energy even to do the simplest task around the house. He did not enjoy conversation with others. His effort to get quality sleep made him frustrated. And what he feared most was dying. Vignette 2, Miss Liz was a 19-year-old pretty lady. She was referred for therapy due to her self-harming behavior. She was deeply unhappy with herself and life in general. Although she went to one of the best schools in the city, she found no meaning in her studies. She isolated herself from her family and friends. After months of therapy sessions, Liz started to show signs of improvement. She came to terms with her growing pains and perception of life. She stopped hurting herself and became more open to making friends and accepting of her family. The third vignette, Miss Slowly was a 48-year-old married woman referred by a sonologist. She had come to get an ultrasound done for pain in the abdomen region. She also complained of recurring headaches. However, her ultrasound results showed nothing significant and was thus referred for her depression. Luli was going through a difficult marriage and stressful home environment. Her husband was an alcoholic for years and sometimes abused her physically. They were unable to provide adequately for the children's education. She made small chutney packages, which are pretty popular here in Nagaland, and sold to make ends meet. She was filled with frustration and shame. Here are a few pictures that I want to show. This was actually done by students and trainees at the CIHSR, where Dr. Sediwe is the head there. Christian Institute of Health Sciences and Research. And I found this to be a great depiction of mental illness. Another one. This is what mental illness looked like for some. I got this picture from a group, a mental health group that I'm part of. And this. On the outside, externally, they may look fine, but they are struggling inside. Some describe it as a miserable life. So what is mental health? Mental health, defined by the World Health Organization, is a state of well-being in which realizes his or her own abilities. That's number one. Number two, can cope with the normal stresses of life productively and fruitfully. And fourth, is able to make a contribution to his or her community. Suffering in these four areas, they become vulnerable to mental illness when they fail to cope and they start developing signs and symptoms. Mental illness describes a continuum of emotional issues from depression to serious brain disorders that affects one's ability to function. The way we feel, think, and behave may be altered. Some common mental illnesses are depression, anxiety, bipolar disorders, eating disorders, substance-related illness, etc. I'm giving here a few signs and symptoms. If we see this in others, or we experience some of this, we need to pay attention. First of all, hopelessness, lack of motivation and interest in the things that we usually enjoy. Okay, a sense of guilt for various reasons, feelings of worthlessness, poor self-esteem. So people don't feel good about themselves. Whatever they do, whatever others say, they don't feel good about themselves. And that leads them to isolation. They tend to shy away from people and they'd rather be by themselves. So they tend to isolate. And they also struggle with sleep and appetite disturbances. They're either sleeping or eating a lot, too much, or too little. And that leads to poor concentration. So when they're unable to concentrate, they lose focus, they become restless. And that also leads to being tired all the time, sometimes crying episodes. For no reason at all, people may feel like crying and they actually cry. And then there could also be some psychosomatic ailments like headaches, backaches, constipation, diarrhea, etc. And of course, suicidal thoughts. Going back here, so one thing about this mental illness is that there is no single reason, okay, or no single cause. There could be several contributing factors why people suffer from mental illness. It could be biological factors, or it could be, because people who lack social support are isolated or are marginalized. They have low self-esteem. Those people are vulnerable. Traumatic life events, losses of all kinds, and environmental trauma that leads to this suffering from mental illness. And so in our society, especially in Nagaland here, there is still the presence of fear and stigma in our family systems and in our society. And we are misunderstood, neglected, and marginalized. And therefore, we need to do something about this situation. And that's why Greg Schroeder's 5-step program, and I've entitled this as Creating Caring Communities. This is something we are. First of all, education. Learn to recognize the symptoms and make appropriate referrals to mental health professionals. Um, I've shown you the signs and symptoms. That's not for us to treat if we are not specialized or trained in this area. But what we can do is provide support the symptoms and make appropriate referrals. Secondly, commitment. We need to be intentional in seeking ways to become a I've put here the example of Fed with Faith. This was a group that my husband was actively engaged in a church setting some years ago. This there was a group of people that met every weekend, and they would cook and prepare meals. And many of these homeless living in the city, they were they had alcoholism and drug addiction problems, homelessness, and all kinds of life problems. So Fed with Faith would go there and just converse with them and be with them, support them. Hospitality. We need to integrate persons with mental illness into the community. Support, create counseling, train therapists, reach out to family members. If you see people who are gifted in this area, provide opportunities and counseling services to them. Advocacy, organize workshops and conferences, support those working on mental health issues, partner with other disciplines and collaborate. And we need to make it visible. These are my concluding thoughts. First of all, early intervention is crucial. In my experience here, many times we see individuals and families coming to seek help very late. And a major hurdle in the recovery process or in the healing process, it becomes harder to treat. So early intervention is crucial. We need more of unashamed conversation. And I really appreciate NSA for willing to take up this topic here tonight. And we need to continue with such conversations. Treat mental illness as you would treat physical illness. A psychiatrist by the name of a dear friend, he recently mentioned, that when we have, let's say, a patient suffering from cancer, then all the families, relatives, people would come and support him or her. But when it comes to mental illness, it's not that way. People would not come the way they would come to the cancer patient. And lastly, healing is possible. There are ways to treat mental illness. And so there's hope, there's healing available. So we need to help each other. All right, so this is it from my side. Thank you for listening.
Thank you so much, Ellen, for that wonderful and much needed wake up call on the reality of mental illness, that it is actually, a disease, and it is existent within our Naga society as well. Somebody had once said that the mind and the body are not separate. What affects one affects the other. Like in the vignettes that you have presented as well, what started as mental, it started, like spilling onto the physical as well. So this is something that we as a society must take more seriously. And I'm sure that all the participants also have really enjoyed listening to you. We will be taking questions and answers later. Right now, we'll be moving on to the next speaker, Miss M. Kyotanglo Choi, Assistant Professor and Clinical Psychologist. Yeah, Miss Kyotanglo, you may take your time now.
Am I, uh, am I audible?
There is a breaking of your voice.
Okay. Is
Now
it
I
okay
think it's
now?
better. Yeah, it's better now. Yeah, we can hear you.
Okay. Okay. I think it's, hi, everybody. Good evening. I'm from the teaching fraternity of University of Delhi, but I will be talking to you in my capacity as a clinical psychologist. I believe we have a lot of academia here, so I will be presenting a case study. And there will be a discussion of how that case study has implications of we as a Naga society, where we are exactly at the mental illness space. I'm grateful to the speaker before me. She has done a lot of she has done a lot of background for me right now, so it's going to be easy. Thank you very much, Dr. Ellen Jamir. I will be presenting you a case. I'm going to label her as LA. Okay, so she's a 25 years old female, did her master's in commerce. She's the eldest of 4 children, 2 girls and 2 boys, is a resident of Dimapur, and she belongs to middle socioeconomic status, identifies herself as Christian. So that's going to be important later on as we discuss the case. She has an adaptive premorbid functioning. Now, this is important because everybody has, now I will also be breaking some myths of mental illness. Everybody thinks that healthy people, you will definitely must have been unhealthy at some point of time. At some point in time, that's why you become mentally ill. Unfortunately, that's not true. Every one of us are equally predisposed. Maybe some of us are more. So if you follow the diathesis stress model, then you realize that some of us are more, some of us are less. When she came to the hospital in Dimapur, she had some presenting complaints. Um, I am going to present a case study. So in case if some of you have a problem with how it's going, then you can please ask me questions, and I'm open to questions also later on. So in the presenting complaints, this is a clinical case study presentation, so please bear with me. The presenting complaints was of a stiffness of body following an episodic tremor. The tremor and stiffness were accompanied by breathing difficulties, cold sweat, and feeling of numbness and choking. During this particular episode, the history of the present illness was presented 8 months back when around 1 a.m. in the morning, the patient woke up with a numb feeling, difficulty breathing, and a feeling that the brain was shutting down and she was about to die. When she was unable to bear the difficulty breathing, she complained to her mother, and then they went to the emergency ward in the hospital. She was given sedatives. They waited out for 2 days, and when she did not improve, then they went to a bigger hospital, from where the necessary physical as well as neurological examinations were done. That included ECG, X-ray, CT scans, blood tests, and all hormonal evaluations that could possibly be done to rule out any physical ailments. When nothing was detected on the examinations, she was referred to a psychiatrist in Dimapur. So she went there, and then she was given anti-anxiety medications, and the treatment followed up for 6 months. There was elevation of the physical symptoms. Unfortunately, the psychological symptoms remained status quo. She did not have significant breathing difficulties to land up in the hospital, but then the psychological symptoms remained, and then she did experience a moderate level of adaptive moderate deterioration in adaptive functioning. It went on for 6 months. Then around 2019 July, there was a death in the family. So a close relative died, and from Dimapur she came up to Kohima. Now, what happened exactly was she was during the process of grieving, she was helping other relatives, and she was still doing fine. Few weeks into staying in Kohima, she made a plan with a friend to go out, and when the friend cancelled, she ended up being alone in the house for some time. During the time that she was sitting alone, she again had an episode. of tremors, numbness. And then this time the severity was more. It was more intense and it was also severe. To that extent where she actually felt her body, from down below, the lower limbs, she could feel nothing. The intensity increased and this came in episodes, so the frequency also increased. When the frequency increased, the family members decided to get her admitted to the hospital. So she went to the hospital and the hospital again did several examinations. When several examinations were made, again, they ruled out physical and neurological problems. So what they decided, okay, we'll discharge her. And then she got discharged. Of course, she was put in sedatives, but she was also referred to a psychiatrist. So she followed up again with a psychiatrist in Kohima, where she was started again on anti-anxiety medications. She was continuing with that medication for 1 month. That's when I met her in Kohima during this time. Over the past 6 plus 1 month plus another few weeks in, that means almost 8 months, she experienced a significant amount of psychological symptoms, but not a single time was she referred to counseling or for psychotherapeutic sessions. When you look at her past history, the patient had twin experience of traumatic events in her life, the passing away of her father at a very early age. And during the time itself, she also had an episode of one-sided interpersonal attraction, which was characterized by bullying, sexual harassment, and threats of physical assault. She never took help for it. She never told her mother because she didn't want to be a burden on her mother. That's the words of the client. Again, a similar incident happened after she left Dimapur for further studies. One time when she came back home, a close relative of hers sexually assaulted her when she was at home. Again, she didn't tell her relative, her family members, and she kept quiet about that. But because she kept quiet and she wasn't dealing with it in an adaptive way, when she went back to the place of her studies, she experienced significant anxiety symptoms. The anxiety symptoms were characterized by suspiciousness, then fearfulness, anxiety reactions. She wouldn't go out, and for 2 months, the socio-adaptive functioning was severely impacted to such an extent that she missed college. She wouldn't go out with friends. There was problem in the normal adaptive functioning like eating, sleeping, and for that matter, social interactions. Again, she did not take help. The symptoms subsided. She managed to just live it through. 1 month before she finally packed the bags to come back to Nagaland, she started ruminating about her own life. What if I'm not able to take care of my mom? What if I'm not able to get a job as soon as I land up in Dimapur? And how long do I struggle? Because I've seen my mother struggling. So 1 month she kept ruminating about that. And between the 1 month of rumination and the first episode of a panic attack, the kid had presenting symptoms of decreased appetite and decreased sleep. There were days when she reported of complete absence of sleep as well. So my title, Maneuvering Identity, Morality, and Mental Illness. I formulated the case because initially she came with a diagnosis of panic attack, which changed. Again, the diagnosis kept changing for her depending on who treated her. Then became conversion disorder, and also was given a diagnosis of generalized anxiety disorder. So depending on who was treating her, it changed. All right. By the time she came to me, the physical symptom had subsided, and people were working around the medications and things were working around on the diagnosis of anxiety disorder. The case formulation that was made initially was of a cognitive behavioral therapy. Now, if you're familiar with it, it basically talks about how negative cognitions impact the way we, the negative cognitions, cognitive schemas of the world, yourself, and the future, how that determines the way you, how that affects and how that leads to the experiencing of symptoms, or for that matter, disorder, and how you break that cycle to actually intervene, right? But here I tried something different. I decided, looking at the case history, the presentation, I decided I'll try something else. So we started on a client-centered therapy approach. If you're familiar with Carl Rogers' concept of humanistic psychology, Client-centered therapy basically sees the individual as a capable, trustworthy, inherently good, capable and trustworthy of making a change. And all of us have the potential of striving towards self-actualization. The reason why I did this, because there was the case formulation. From the case formulation, you kind of get to see that the identity that she had as an individual, then the moral identity that she had, all of those were at an incongruent state. So applying a Carl Rogers concept, the case was formulated as Miss LA suffered a traumatic event at a very young age, which made her ignore her needs and anxieties. She learned to prioritize the lives of her significant others while trying to dissociate herself from what she was feeling and experiencing and what was expected from her. So being an ideal daughter and seen as a very responsible daughter, that was the identity that was, it's called the ideal self. So if you are familiar, again, the concept of ideal self versus the concept of real self, the real self it was getting tested and tested, but then and the breakdown happened. The case formulation assumes that the breakdown happens because there was a incongruency between the real self and the ideal. This was the other one was, of course, the concept of the moral identity that she had, perceived as a girl having a moral character, but then the kind of assault that she had when she was in her late childhood, and then also the fact that she was again sexually assaulted as a young adult. Those challenged her on the idea of her moral identity, and also the fact that during the process of illness, people calling up on her, and the fact that she perceived the illness as a punishment for the mistakes that she could possibly have made, or she had made. So those came into conflict. All right. Then again, so the first episode as well as the second episode, they are explained from a client-centered therapy perspective. Why a client-centered therapy, and why are we assuming that this is going to work for her? Because of the kind of view of nature that's provided by the theory. The fact that it's aimed at at helping the client achieve a greater degree of independence and integration. Because remember, again, I'm here as per the case history, the history of the present illness as well as the past illness. You are getting to see a client whose identity is incongruent. There is a lot of incongruence between the real self and the ideal self, what is expected of her and what she's experiencing. All right, and then the concepts of client-centered therapy, like for example, genuineness, empathic understanding, then giving unconditional positive regard. All right, so these are assumed to have a positive impact and a positive change in the client. All right, and I'll come back to what are the takeaways from the case, because we don't have a lot of time, already 12 minutes up there. So I'll quickly give you the takeaways from the case. First thing is, even a well-functioning individual can experience mental illness. We always have this assumption that, okay, no, maybe unhealthy people, somebody who doesn't have a good lifestyle. It's not of the lifestyle. We can read on the diet assist stress model. It clearly tells us that there is something called a predisposition. You give a stress to it, you give a certain stress to it, and the predisposition can be in many forms, could be biological, psychological, social, cultural, also for that matter. From this case, particularly from a Nagaland context, even in metros like Delhi, if I'm the third professional to be contacted for treatment, then in Nagaland, the client usually will not reach me, because this is a mental illness and chances that the client will not reach me. The third one, diagnosis is a huge problem in Nagaland. Psychodiagnostics, I called up a lot of people when I was there in Nagaland, and I did not get a person who would do psychodiagnostic for me for this client, because it's really important to get a psychodiagnostic done for this particular client. When I came back, because I'm settled in, I'm here in Delhi, I'm settled in Delhi. And when I came back, because the kid was still there, the patient was still there in Nagaland, I couldn't find a clinical psychologist to refer to. So again, the fact that, you have a mental illness issue, but then you don't have someone whom you could reliably ask someone to follow up, right? Because there may be somebody, but then again, it's a talk therapy. So client, the rapport formation is also something that's very difficult. And the patient did not get somebody with whom she could be comfortable and then continue therapy. Unlike physical ailment, again, it's not about the competence of the therapist alone. It's also the comfort of the therapist and the client that determines the effectiveness of a therapy, or for that matter, even whether a therapy actually functions or not. The third one, I would like to point this out because I think it's very important from a Nagaland context. The treatment of mental illness cannot be praying or staying isolated in a prayer center, because this was constantly suggested to the client. And she was already having a moral identity crisis. And people coming and praying was a constant reminder that maybe it's her fault, it's her fault. So the guilty feeling again generated more anxiety. So I think clearly, you know, therapy, from therapy perspective, we need to be able to differentiate between what is a spiritual need and what is a mental illness need, you know. That I feel is a discussion that's really missing in academia, in Nagaland. Right. Then, of course, if you experience ill health, please seek help. All right. So much is ignored in Nagaland. When I keep going home, when I meet students from Nagaland here, you know, so much is ignored. Suicide, then child sexual abuse. It's real, and it's not just girls. Equally affects boys, right? And then LGBTQ issues, so much is ignored in Nagaland. And I think just to conclude, I'm exceeding the time. So just to conclude, I think given an environment of genuineness, empathetic understanding, unconditional positive regard, every one of us have the potential to strive for self-actualization. So maybe we, as you know, in mental health, or for that matter, general health also, we should strive to, you know, give that kind of environment to each other. Thank you very much. And Jasmine, if I may, you know, later on, if I can take that question on.
Yes, you will all be
Somebody
given an
wrote-
opportunity to respond. Already questions have come for the speakers before you as well. We will be having the Q&A towards the end. But thank you so much, Kyotung Lo, for demystifying and busting the myths around mental illness. Your case study has also in, you know, so many ways helped us lay people to understand mental illness, and also equip us to be more empathetic listeners, because as somebody who's also, you know, teaching and engaging with a lot of young students in Delhi University, the first thing that we're told as teachers, because we also are put as teacher mentors, the first thing that we're told is to not pass judgment and to listen. And I think it all starts with accepting and understanding the fact that we're all equally susceptible in different degrees to mental illness. And it's not because of particular, you know, different contexts, but all of us at different points of time, I think we're equally susceptible to it. And I think this sort of helps us also to understand, you know, understand mental illness as something very normal and something that we need to address openly in our Naga society. So thank you so much. You were an excellent and engaging speaker, but also an excellent timekeeper at the same time. Now, next up, we have Dr. Kyobini Moji. She will be speaking on the topic of indigenous genomes in the era of precision medicine and big data. Dr. Moji, yeah, now you may take your time.
Yeah, hi. So I'm going to share my screen. Let's see. Do you see my screen yet?
Oh, yes, you can. You are one of the hosts. You can do that.
Okay. So am I sharing my screen?
Just wait for a while. I think it's yet to come.
Okay. Well, okay. So I just don't want to waste time.
We can just wait for a while. I hope Rizwan, can you help her?
I think, okay, maybe I shared the wrong screen.
Okay, now it's coming.
Yes, we
Okay,
can
great.
see.
Yeah.
Yes, the screen.
Awesome. So I'm going to set my timer. My research is sort of broadly in the area of genetic epidemiology. So I'm going to talk about a topic that's related to that. And my email is here. If you have questions, you can always email me. So a lot of people say that we're living in this post-genomic era, or the era of very big data, you know, and whether it's the huge genomic research or whether it's direct to consumer genetics like 23andMe, where, you know, you pay them money, you give them your saliva and they get your DNA and give you your genetic results, or whether it's corporations like Amazon and Facebook, you know, these entities are constantly scraping a lot of data from us. And so the fact is that data is the new commodity and it's the new currency. Now, now our DNA, I'm sure a lot of you are familiar with it. It's a tiny microscopic cluster of molecules, and it's really simple and beautiful. But as tiny as it is, it's a huge database. It's got this capacity to store a lot of information. So if you had 1 gram of synthetic DNA, you can store 215 petabytes of data, which is a lot of data. So it's an information-rich molecule, but it's simple because it's only made up of 4 alphabets. That's the basis of the genetic code. And these 4 alphabets, A, T, C, and G, each represent specific chemicals called nucleotides or bases. Now, the human genome, now we know that the human genome is made up of a little over 3 billion bases, so 3 billion alphabets. And you can think about this as the bare bones instruction manual on how to make a human being. So what I mean by that, we're living in the post-genomic era, is that it's the time after the Human Genome Project, which started on 1st October 1990. And this project has this ambitious goal of sequencing the entire genome. So prior to that, we had like red little pieces here and there, but we didn't have the whole book. So the Human Genome wanted to sequence every alphabet. So it started in 1990. It was mostly funded by the US government, but it became this international project. And the technology was a little bit different than what we have now. It was not as good. And so it took about 10 years. And it also ran into some legal issues about who actually owns the data. And around spring 2000, even President Clinton got involved, and they reached this international agreement that no one can patent the human genome. And then it was finally, the project was completed in 2001. The first publication was from this publicly funded work, which is the work that was done by institutes and universities. And then a day after that, a second publication on the human genome came out that was led by a corporation called Celera Genomics. And the timing of these 2 publications was intentional and coordinated, because by allowing the public data to come out first, it essentially precluded any private entity from claiming ownership of the human genome. So the data basically belonged to no one, but in essence, it belonged to everyone. Now, fast forward to now, 2020, we can actually sequence an entire human genome in a day. So what took 10 years, now we can do it in a few hours. And not only the speed, but also the cost of sequencing genomes have dropped drastically from $100 million to now, a little under $1,000. So if you have $1,000 to spare, you can technically get your genome sequenced. But now we're living in this in a world with like a data deluge, because now we have so many human genome projects, and like the 1,000 genomes, and every year they keep getting bigger. Most of these are from institutes and nonprofit organizations, so they're public, they're in the public domain. Some of these are private, like the Icelandic Decode project, which basically owns data on 1/3 of the population of Iceland. So that has led to some debates on ownership and access. So, someone would say, it's my DNA, so I have the right to own my own data. But someone else would say, well, Decode paid for it, and they generated the data, so really they own your genetic data, and they can decide how much access they want to give you. So that's a debate. Now, I've highlighted the Human Genome Diversity Project here because one of their goals was to include indigenous populations, which I think is a great thing because, I want people like us to be included in this genomic wave. I don't want us to be left out. But it also led to some controversies and concerns about exploitations and overuse. Now, if you think about the major goals of these large-scale genomic projects, it's nothing nefarious. They all really just want to benefit people. So their main goal is to understand genetic variants that cause diseases, because they will help identify targets for drug therapy. And so that's great, right? That's nothing bad about that. And that means that it will be profitable to some pharma company that invested in it, but it also means that it'll help cure diseases. And it'll facilitate precision medicine, which is the idea that you can customize treatment to the individual. Sorry, it's early morning, so I'm like, and so it's nothing bad. The intentions are not bad, but right now we have this tug of war between the potential good and the potential bad. So it could benefit humanity. You're pushing the frontiers of human knowledge. But someone else would say, we're pushing the frontiers of human knowledge a little bit too much. They're not very comfortable with that. Now, one potential bad that is particularly relevant to indigenous populations is the potential for overuse and misuse. And so I'm going to use the example of the Havasupai people. This is called the Havasupai fiasco. The Havasupai are indigenous Americans, and they live in the Grand Canyon area of the Arizona state. Now, back in the 1990s, researchers from the Arizona State University, they started collecting blood from the Havasupai people. And their goal was to study diabetes. Now, the Havasupai people almost never had diabetes before, but in the modern era, this disease was raging in the community. And one can always guess that this is probably because of their exposure to Western diet. And this is something that I see a lot of parallels with us Nagas as well, because I think that in the last few years, companies like KFC and Pizza Hut, they've made significant inroads into our communities. And that is very concerning to me. But anyway, the tribe members consented to that study because they thought, that's going to be good for them. It's going to benefit their society. However, later on, the researchers decided to include other topics like schizophrenia and mental health. Now, it's not like the researchers did not get consent from the tribe. They did, but they used a very broad consent form, and the language was not particularly clear. And then later on, they also ended up studying things like alcoholism and inbreeding and migration. Sorry, I have a little bit of a sore throat. It's not COVID. So anyway, there were several instances of ethics violation here. One of them is that the study was not treated as a partnership. The scientists pretty much treated the people as study subjects. And also, there was lack of clarity in what they consented to. So they did get consent, but it was not necessarily informed consent. The tribe members may not have totally understood what they were signing up for, because this is in the 1990s. Many of the Havasupai people may not even have graduated high school, and English may not even have been their first language. So that was a problem. And then the researchers overstepped their boundaries, right? They started studying stuff that's taboo to the tribal people, the mental health. They turned alcoholism effectively into a biological problem, and they ignored the fact that this is actually a societal problem because the Havasupai people have, had history of mistreatment and stress and adversity. And their study of migration also conflicted with the indigenous narratives of their own origins. So what ended up happening was Arizona State University ended up having to pay a lot of legal fees, ended up paying some money to the Havasupai people. And unfortunately, now the Navajo Nation and other Native American tribes have now temporarily halted participating in genetic research, which I think is a little bit sad. So, and I hope it'll be temporary, because the fact is representation and inclusivity is crucial in genomic research. Now, it's a balancing act. On one hand, we don't want to be exploited. We indigenous people are vulnerable and all that. But on the other hand, we are also rare populations. Our genomics is incredibly interesting, and we can help push the frontiers of human knowledge. And we don't want to be left out. And the other thing is that this might not sound very relevant right now to Nagas, but we also don't want to be left out from therapeutic research. We don't want therapy that works well in us, because the fact is, not all drugs work optimally in all people. So I'm going to take the example of Plavix, which is a drug that's used to treat coronary disease. Now, in the year 2014, the state of Hawaii sued the manufacturers of Plavix because they had misleading advertising. The reason is because Plavix does not work on all subpopulations, depending on your genetic makeup. And this is specifically because of a genetic variant in one particular gene called CYP2C19, and that's involved in drug metabolism. And the fact is, I know that I carry one copy of this non-functioning gene. So I know that if I ever have to take Plavix, I should be cautious about it. So, and the reason is because more than 50% of East Asians and Pacific Islanders, which is the genomics that we Nagas share, we carry the risk variant, which makes us less responsive to Plavix. On the other hand, Europeans, they carry, only 27% of Europeans have the risk variant that makes them non-responsive to Plavix. So the state of Hawaii is majority East Asian, and that was the basis of that lawsuit. I don't know if the lawsuit went anywhere, but that tells us that our own genetics is incredibly important in drug therapy. And these are other examples, a couple of examples on precision medicine. There's one is warfarin, where you can take your genetic test and it can help you decide what your safe dosing is, because in some people, warfarin can result in bleeding. And then another drug is Herceptin, which is a targeted antibody treatment against breast cancer. But it only works if you have a certain type of breast cancer, where you have the HER2 positive breast cancer, which is, you express that gene. But it doesn't work if you have something called triple negative breast cancer, which is much more frequent in African Americans. So the fact is that most of the drugs are designed to work optimally in one cohort of people, which are usually of European ancestry, and may not work optimally in other populations. So we want to be included in these types of genetic studies so that drugs work as well in us as it does in someone else who's maybe white. This is my concluding slide. So what's the solution? I know we are a little bit behind, like we're probably not there yet, but it's coming, and so we want to be prepared for it. And I think one of the solutions is to look at genomic research as a partnership, which means that the only way we can do that is through education and community involvement, which means we need more indigenous scientists and doctors coming out so that we are both researchers as well as research subjects. And I highlight this paper that came out a couple of months back, because I think this is a landmark article that shows how we as vulnerable groups can overcome what's been called academic colonialism, which is when you're studying Africa, but all the scientists are from Europe or the United States. The very cool thing is that back in 2017, the San people, which are the Bushmen of Kalahari, they set their own code of ethics in genomic research. So they say, we're going to participate in genetic research. We're not going to stop you from working on our DNA because our DNA is incredibly interesting. But if you want to study us, you need to abide by our code of ethics, which is really empowering. And I think this is a paper that came out. I think that kind of represents the effort, because majority of the authors in this paper, 23 out of the 32 authors, are based in Africa. And of course, there are some, Europeans and American authors, but this is largely a paper that was published by African authors. The funding too, the fact is genomic research is incredibly expensive, but this funding it came from Africa because there were 12 African nations decided to chip in money so that they can study their own genome, which I think is a beautiful thing. And of course, there were major donors from the NIH, which is in the United States, and the UK Wellcome Trust. But the fact is, where the money comes from is not as crucial as the community involvement. So that's my take This might be a little bit off topic, but but thank you for this time.
Yeah. Thank you so much, Dr. Kyobini Moji. I have to admit that I'm a humanities person. So 70% of your talk was, like out of my depth. It was just, like bouncing off my head. But of course, it was extremely fascinating. And one of the takeaway messages for, a humanities person like me is that genomic research is extremely important, even for our people, for the Naga people. And I think we need to bridge the gap by encouraging more Naga scholars to take up research in this area so that, citing from your words, we can be researchers as well as a research topic. So thank you so much for enlightening us with that very interesting, presentation. We will be taking questions in a bit, but now moving on. I would like to now give the time to Ms. Pansi A. Jami and Chamtong Loyanthan, research scholars from JNU, for the paper on the role of women in sustaining indigenous food knowledge of the Lotha Nagas.
Good evening, everyone, and thank you, NSA organizing team and the chair for giving us this time. I will be switching off the video as there is connectivity issue.
All right, no problem.
The title of our paper is Role of Women in Sustaining Indigenous Food Knowledge of the Lotha Naga. The Lotha Naga is one of the major tribes of Nagaland and mostly concentrated in the Wokha district of Nagaland. Wokha is also known as the land of plenty. As the name suggests, the region is ecologically rich and endowed with abundant natural resources. A large number of people are dependent on agriculture and forest produce for their livelihood. The agriculture system and the forest provide a variety of human needs, particularly owing to sustenance and food consumption. In this paper, food is used as an important component to signify the important role of women in food preparation, but most importantly, their role towards sustaining indigenous food knowledge in the face of a globalized world. In the Lotha Naga society, the kitchen is the most important place within the house, and traditionally women are assigned to hold their domain in the kitchen and do household work like cooking, cleaning, fetching water, and collecting firewood. Women are largely responsible for food selection, food preparation, collecting indigenous material from the forests and kitchen gardens. The indigenous knowledge of different food practices performed by women among the Lotha is a significant aspect to understand the dynamic role played by women in sustaining indigenous food knowledge. Study also shows women often have unique perspective as well as proper understanding of local biodiversity and management of related natural resources. Women have conserved many local crops, ethnic vegetables, and indigenous fruits used in the local diet for food and nutritional security that plays an important role in sustaining a variety of traditional food. Variety of herbs that also have medicinal properties are grown in the kitchen garden, and eatable wild plants found in the region are also used for the treatment of many different kinds of ailments, but its nutritional value is not yet documented. People in this region possess a great treasure of traditional knowledge system pertaining to agriculture, food, and natural resources management. Today, Lotha women continues to effectively contribute by growing their own food, selling it, and procuring it, which helps in reducing poverty and hunger and also boosts the economy for the community. The skills and knowledge possessed by women are translated into economic empowerment. Being able to grow traditional produce is as important as knowing how to prepare it. Food are not only being produced, but women are also responsible for the method of preparing, preserving, and storing the food. Trials and error experiments contribute to developing many indigenous methods for preparing and preserving food. There are two main methods of preserving the food. One is sun drying and the other is fermentation. The present paper emphasizes on the importance of sustaining indigenous food because most of the food grown by women is organically produced and the utilization of locally available vegetables is a common practice among the Lotha Naga. Besides many edible plants and vegetables, bamboo shoot is important food ingredients used in different traditional food cuisine, which does not only add flavor but also contributes to traditional delicacy, and the Lotha Naga use it in different ways: dried, fermented, and raw. Studies show dry or fermented bamboo shoot contain probiotic properties and vitamin P suppliers to the body. Bamboo is also considered as nutrient rich species because
Hello, Pansi. Yeah. Excuse me, Pansi, we can't hear you properly. Hello?
Maybe some network.
Pansi, are you there? Pansi, excuse me, are you there? Can we move on to the next paper in the meantime while waiting for Pansi? I think she has some network issues at her end, so we can allow her to complete her paper in a bit. In the meantime, let's invite Miss Akwana
Am I
Rimai.
audible?
Are you back? Hello?
Yes, I'm back.
Okay, all right, yes. Then we'll allow Pansi to complete her paper and then we can invite the next speaker. Yes, go on, Pansi.
Okay, thank you. Uh, Today, eating highly processed food and unhealthy diet has led to increasing lifestyle-related disease, and people are now emphasizing local cuisine that are organically produced. There is a growing number of demands for safe and organically produced food across the world. Therefore, that indigenous knowledge of food practices should continue to practice and pass down to the next generation. Moreover, food is an integral part of cultural identity, and it plays a significant role in representing one's identity through food cuisine. Therefore, promoting indigenous food knowledge gives impetus to traditional values, as mentioned by Sibal, that there is an intrinsic link between food and culture, where food is used as a means to signify and retain the cultural identity, and people often connect their culture or ethnic group through food pattern. The current changing trends. Today, due to the changing economic trends in the state, women also carry the knowledge of indigenous food cuisine beyond our state in a city like Delhi, and those women play an important role in promoting indigenous cuisine. Over the years, it is observed that people from other parts of the world have grown to appreciate the taste of our food, which creates a wide scope to push economically for women. Moreover, the current trend also shows how social media have become an important site to promote indigenous food knowledge. There are vlogs and pages on Instagram run by women that gives a tutorial on traditional food. And through this, Lotha indigenous food is gaining wide recognition in today's globalized world. The impact of the pandemic. The sudden occurrence of pandemic across the globe has devastated local market at home. However, it has also necessitated the importance of reviving indigenous food knowledge on cultivation and preparation. especially the younger generation who are living outside for employment and education purpose, are on the verge of losing the touch of traditional values and practices. But these people are now relearning and rediscovering the importance of traditional knowledge of food, as it also plays a vital role in meeting the requirement of food need in the household. During our interaction with few people for the purpose of this paper, we found out that men who have returned home from cities are seen actively engaged in domestic affairs, especially in cooking and farming. So the study also shows that there is a dynamic change in gender roles where both men and women play a vital role in retaining as well as sustaining the importance of traditional food knowledge. Therefore, though the pandemic has affected our life in many ways, in this regard, it is safe to say that the cause of pandemic offers an opportunity to revive our traditional food knowledge practices.
Hello, Pansi, are you done? Hello? Are you done? I think we have lost her again. So, since we're already running behind time, I'd like to call on the next speaker, Miss Akwana Rimei, who is a research scholar from NEHU. She will be speaking on the topic nutritional status in relation with the place of residence among the Rongmai Naga of Manipur. Miss Rimei, you may please take your time now. Miss Rimei, are you here? Akwana Rimei? Hello, are you there? Has she been muted? No, she is a co-host. We can't hear you. We cannot hear you, Miss Rimei. I can see that you are there. Hello? Miss Pansi, are you back? Okay, while we're waiting for Miss Rimei, since we are already, yes, running out of time, let us go ahead and start addressing some of the questions that have been put here on the chat box. Whenever the last speaker is back, we will be inviting her to present her paper. The first question here is, I don't know, the name is not given. It's from, I think, an Oppo phone, yeah. And the question is for Dr. Sedevi Angami. Sir, it is always a pleasure listening to your talk. I would like to have your further views. How can a community, or rather, how a community should develop a sustainable economy when one cannot take care of oneself financially, especially the eastern parts of Nagaland? If I'm not wrong, during this COVID-19, they have extended a great help. Dr. Sedevi, would you like to respond to this question?
Yeah, thanks for that question. I'm not an expert on Eastern Nagaland, although I have been to all parts of Nagaland and especially to Twinsang quite a lot of times. And I think although people do talk about Eastern Nagaland as being less developed than the rest of the state, uh, I'm sure all of you know about Chingmak and the kind of work that he's been doing there. And we realize that even in a land where it seems to be less developed, people are doing fantastic amount of innovations and community development, which is actually exemplary and can give us a lot of ideas. So I feel bad that he hasn't shared all his innovations to the rest of the state. And I feel we've got too much to learn from him. And therefore, it's not because Eastern Nagaland, is less developed. I think they're equally they may not have had as much opportunities because of the distance and things like that, but in terms of innovation and things like that, they can do equally better, equally good, or even better than us. So developing a sustainable economy is perfectly possible, even in that place. And the kind of innovations they have done in health, like the ECS taking over the midday meal in Twinsang and several parts of like Longlang and Mon also, that's something nobody has done. You know, you go to Dimapur, the Danseri part block, which we have adopted. You go there, the public distribution system is non-existent. Midday meal is non-existent. But what they have done in Twinsang is phenomenal. So I feel that we should not say that Eastern Nagaland or the rest of Nagaland is different. It's just that you take the initiative, you can do it. The land is equally rich. Yeah. There is enough starvation even in Dimapur, okay? In fact, recently we were discussing in the district task force, and one colleague of mine said, there is no starvation amongst Nagas during COVID-19 times. And that was an absolute lie. He didn't know anything about what he was talking about. So we know because we go and meet people on the ground. And yeah. So it's equally bad, both this side and that side. But I think there are people there who are great innovators and they can teach us a lot.
Right. Thank you so much, Dr. Sedevi, for responding to that question. Is Miss Rimai here? Akwana Rimai? Nehu, are you there? Okay. Then can we go ahead and take the second question? This is for Ellen. This is from Joy Chaudhary. She has asked a question here, especially in the context of Nagaland and the Northeast region. Vignette number 2, Miss Liz. What would be the possibilities of NLP techniques for addressing Miss Liz's challenges and hopefully possibly cut shorter the months of sessions? Ellen, would you like to respond? Yeah.
Yeah, thank you, Mr. Joy, for the question. I have to admit that I'm not trained in this and I don't use these techniques or methods. But in the case of Miss Liz, what I found out was it was more of a developmental issue and her relationship with her family system. So we addressed that and it seemed to help her. And I think Dr. Kuo Tung Lu has responded to the same question later on. Yeah, thank you.
Thank you, Ellen. The next question was addressed to Kyo Thang Lo from Joy Chaudhary again, but I can see that chats have ensued then, so I'm assuming that Joy Chaudhary's question has been resolved. I'm going to move on. Yes, please.
Sorry to butt in, but can I just make some few clarifications for him again?
Okay, all right. Please go ahead. Yes.
Thanks.
The question is on the chat box. Yeah.
Yeah. So besides what I have replied, I think there are some misconceptions that's coming in. That's something that's so obvious in the reply, the query that has come in. First, for mental illness, pharmacotherapy alone doesn't work. So because I had so much to talk about, maybe this sentence I missed out. Mental illness has to be treated through a multidisciplinary approach, which is very obvious. Assuming, and over here again, she obviously is not sick. Well, that's a wrong assumption. Conversion disorder is a mental illness. Okay. When I saw her, the obvious physical manifestation had subsided because she was already in contact with a very good psychiatrist. So she was already on pharmacotherapy. But then the affective and the behavioral component of anxiety was still remaining. For me, it would have been an easier choice to have a CBT option for the client, but then we opted for client-centered therapy because the case study showed us something else. And on behalf of both Dr. Helen and I'm sorry, but there is no shortcut to therapy in mental illness. This is exactly like the way, parents come to our clinic and then they say no. A tantrum of a child, I'll give an example. A tantrum of a child takes months and years to learn before it even gets manifested. But the moment the parents come, they'll come and tell you, acha, 2 हफ्ते में ठीक करके दे दीजिएगा, you know. It's like, how can I treat a behavioral problem which has taken years to develop? How can you expect me to treat that in 2 weeks? So please, there is no short-term therapies until and unless you have short-term psychoanalytic. Those are different. So again, we're talking about human behavior, thoughts and feelings. So there are no shortcuts. Also, the therapy cannot be used for the same kind or similar kind of disorder. Unlike the MDs and EMS, you know, we don't have a prescription that fits the same diagnosis. Every treatment is custom made. So I think that's really important. And as far as NLP is concerned, I think I've answered that query. It's an adjunct, okay, but that is also only for some problems. Again, effectiveness is doubtful. In clinical practice, we definitely do not use it. So I hope that answers the question.
Okay. Thank you, Ms. Kyotanglo. There's a question here for Dr. Moji here, Ms. Kyobini. Yes, I'm just going to read it across to you. This is all Greek, but I'm going to anyway read it out to you. This is from Graham. He says here, thank you for a wonderful talk. Professor Francis Collin and his team have done a wonderful job by sequencing the human genome. I wanted to ask a question with respect to the broad theme for this technical question, mental health. Supposing my genome sequencing show that I'm carrying a lethal gene that may cause several health issues when I cross 40 years or so, how do I respond to that? For a person who is strong, healthy, and young, don't you think the finding may lead to several mental crises? One may say that the presence of the particular gene will not mean that you will get 100% get the disease, as there is epigenetic regulation that is involved for the expression of a gene, which is largely regulated again by the environmental factor. However, how can the scientific community educate such a complex mechanism to the people who most of us struggle to even use a phone? Over to you, Dr. Moji.
Yeah, that's an excellent question. Really, what we've learned is that genetics is not deterministic for the most part. And this is actually, the question is a whole can of worms. There are very few genes that we know of that can increase your likelihood of a certain disease in a very predictive way. One of those would be the ApoE gene, which increases your likelihood of developing dementia by the time you're in your 40s and 50s. So the thing is that most of the genetic variants are not actionable, as in we don't know if we can take steps to prevent them. In that case, we run into an ethical dilemma of whether we should tell the person or not, and whether the person wants to know or not. And for that, we leave it up to the individual. So when we're doing genetic studies, sometimes we find things that are incidental. So we find a gene that says, oh, this is going to cause something like, dementia when this person is in his 40s or 50s, or it increases the likelihood of causing dementia. And so is it up to us to tell that person or not? That's a whole can of worms. So a lot of these mutations are not deterministic. So we really don't have authority to tell people, oh, you have this lethal mutation, because there's no such thing as a lethal mutation. There are very few examples. One of the examples would be the BRCA mutation, which causes breast cancer. And that is in fact actionable. Because if you find a mutation that can increase the likelihood of causing breast cancer by 80%, and you can do something about it, then you tell the person and they can take precautionary steps, like they get exams and they can even do a mastectomy and things like that. So when you have a genetic variable that can cause a disease and it is actionable, as in the person can take actions to prevent it, then we can tell. However, for the most part, most genetic variants are not deterministic. So there's this whole likelihood that it may cause disease, but it may not cause disease, because almost every disease that we know of are what we call complex phenotypes. It's not caused by one gene. It's caused by an interaction of the gene with the environment and a number of other stochastic random factors. And that's like, the question mentioned epigenetics. That's actually a really important part of the research that we do. And so, yeah, there's no such thing as a lethal gene that's going to kill a person, when he turns 40. It's not deterministic.
All right. Thank you, Dr. Moji, for taking that question. I see that the previous speaker, Ms. Pansi Jami, is back, and since she was cut off in between her presentation, Pansi, would you like to take a minute to wrap up your paper? I know we're running out of time, but since you were cut off
Am I audible?
abruptly, yes, you're audible. And I request you to please sum up your paper now in a minute.
I was on the verge of concluding, so I think that will do.
Okay, you're good with that?
So my last, yeah.
Okay. Thank you then, Ms. Pansi, for that wonderful paper that you have presented on, women as culture keepers, indigenous knowledge keepers, and stakeholders in the economy. And it is for a fact that food is definitely a need for filling the tummy and for sustenance. But in today's world, we see that food is also empowering and giving an identity to women. So thank you so much for, bringing that perspective of, how food is also an empowerment to women. I would like to now give one last chance to the last speaker who has been having a lot of internet connectivity issues, Miss Rimay. Are you there? She's been having a lot of internet.
Hello.
You are
Yes,
there.
I'm here.
Okay, yes. So
Okay.
let's, let's check your internet and see whether you can, go ahead with your paper now. And since we're running out of time, Rimay, can I request you to please wrap up your paper in 10 minutes?
Okay, sure. I'll try to do that. Thank you so much. Thank you so much for the organizing committee, SA, and to the chief for giving me this privilege to share my paper. And today my topic on nutrition in women with age and place of residence among the adult Roma Naga Manipur. And I would like first apologize for the slight change in the topic of my paper with some additional word. And I will go to the introduction of my paper. BMI study has been useful in knowing health and nutritional status of a population. It is widely accepted as one of the base anthropometric indicator of the nutritional status of adult individual and population. Obesity is a complex, multifactorial chronic disease involving genetics, perinatal, and environmental components. The condition is a major public health concern because obesity is a key risk factor for a range of chronic illness, including hypertension, diabetes, heart disease, stroke, gallbladder disease, biliary callus, narcolepsy, osteoarthritis, asthma, apnea, gout, and sudden cancers that tend to reduce the quality of life and ultimately results in death. Additionally, a significant number of obese patients tend to suffer from mental disorder and social rejection, leading to loss of self-esteem, particularly sensitive issue in the case of children. A number of studies have found that overweight is associated with increased prevalence of cardiovascular risks, such as hypertension, unfavorable blood lipid concentration, and diabetes mellitus. Adults are the major contribution to a population growth and development of any society. So study of adult health is very much in need of time and can be studied by looking into the health status. World Health Organization, WHO, 1917 defined human health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. In order to elevate the health status of adults, we should know the present conditions. Health is closely interwoven with proper and adequate intake of food and nutrition. How well the body function is a direct reflection of what we eat, how much we eat, and the balance between the two. Thus, the nutritional status of an individual is often the result of many interrelated factors like food intake, quality, ecological condition, socio-economic status, and physical health. Walensky and Malik, 1979. An adequate diet with the proper nutrition in the right amount as required by the body is considered to make an individual healthy, while poor diet characterized by intake of inadequate or excess nutrients is related to the need can be adversely affect the normal functioning of the body. Thus, nutritional assessment help to identify individual or population group at risk of belonging malnourished or who are malnourished. Hence, to understand the health status of any population, it is important to assess the nutritional status of the population. Materials and method. In the materials and method, I would first like to mention the population. The population studied are among the Rongmais, and Rongmai, locally pronounced as in Rongmai, are indigenous people found inhabiting in the northeast India states of Assam, Manipur, and Nagaland. In Manipur, they are found concentrated in Tamenglong district with a large number of pocket villages in the valley district of Imphal East, Imphal West, Thoubal, and Bisnupur. Racially, the Rongmai are of the Southern Mongoloid descent, and linguistically, they belong to the Tibeto-Burman group of Southern Mongoloid. Ramkun Pamay, 1996. They are referred to as the Sado tribe. Their physical features are by and large similar to the other group of Northeast India and people of the neighboring countries of Southeast Asia. They are also said to have been migrated from China's Xinjiang province, Namchubuyang, 2021. For the studies, 7 villages of Rongmai in Manipur were selected. And from the 7 villages, it is divided into rural and urban. Tamenglong district as a rural area and Imphal East district as a urban area. 338 households were covered, and from there, 678 individuals aged 18 years till 16 years were interviewed. Age group were categorized into 4, 18 to 28 years, 29 to 38 years, 39 to 48 years, and the last group are 49 years and above. Height and weight were measured following standard protocols using a weighing machine and anthropometer rod respectively. BMI were classified following Asian cut-off values, WHO 2000. Underweight less than or equal to 18.5, normal 18.5 to 22.9, overweight 23 to 24.9, obese greater than or equal to 25. MS Excel software, Microsoft company's 2007 version were used for the basic analysis, and IBM developed software SPSS version 23 were used for statistical analysis, and p-value less than 0.05 were taken as significant for all the statistical analysis. And I am sorry to say that I won't be able to show the tables which I prepared because I couldn't connect it with my system, but I will be going to the result. I will be going to the discussion and conclusion along with the result. In the present studies population, in this category, is it 29 to 38 years is found to be the highest with 10.88%. Among the Rengma Naga of Nagaland, also the prevalence of obese were documented to be higher among females than the male. Among respectively, among the Rengma population of Naga also, mean BMI, height, and weight are higher among the male and lower among the female, which is also the same case of that of the present study, as which is there in the table. But I'm so sorry that I couldn't show present contrast.
Hello. Yeah, looks like there is a problem in connectivity for Miss Rima again. Of what she has shared so far, is there any question that anyone would like to pose? If not, then since we've already we're already actually past the timing given for a session, so I think we can close the session. We're so sorry, Ms. Rimay, that we were not able to listen to your entire paper, but yeah, thank you to all the participants. Thank you to all the paper presenters for sharing from your expertise the range of enriching topics, which, although, like I admitted, some of us in humanities might not have really understood every terminology, but it was very, very enlightening and an educational experience. I also offer my apologies on behalf of the chair, Dr. Sushmita Dasgupta, should have been the chair for this session. I was the organizer only, but due to an emergency in her family, she could not chair this session, and so I had to step in. So thank you, all of you, for for your patience and for joining in. And yes, yeah, I think the president would now like to share something. Would you?
Okay, let me come in. First of all, I would like to congratulate Nzanmungi Jasmine Badon. She's the chairperson. I mean, like, she is supposed to be the only session
Organizer, yes.
but very unfortunately, Dr. Susmita Dasgupta, who is a very close friend of the Naga Scholars Association, could not join us because of a sudden, like, unfortunate situation at her place. So we really want to thank Jasmine for very efficiently, like, running the session. Thank you very much, Jasmine. And I would like to congratulate all the speakers for such a like powerful presentation, and we look forward to even having more conversation even in the days to come. And well, I would like to like, invite you for tomorrow's session. Tomorrow is the last session of the international webinar, so I would like to request all of you to kindly join us. Yeah, thank you very much from my side. Yeah. And of course, I would like to give thanks to the Repodiers, the good Repodiers. Thank you very much. And also a very special thanks to edu trainer, especially Rizwan, who has been really working hard in giving us such an efficient technology, technical support. Thank you very much, edu trainers, and thank you especially to Rizwan. Yeah, thank you, and have a very good night from here.
Yes, yeah. Thank you so much, the reporters, Pangartoshi Waling, Rinchuila Shimpuri, and Dr. Silas Wongrampa. My apologies, for not acknowledging you earlier. And thank you so much, everyone. Then see you all tomorrow.